Iatrogenic lung disease. Etiology. A number of respiratory conditions may be precipitated by standard medical therapy, either by damage to the lung parenchyma or by disturbing pulmonary physiology. These effects must be remembered when prescribing such treatments, and highlight the importance of taking a thorough past medical and drug history when interviewing patients. Potential mechanisms include bronchoconstriction, alveolitis/pneumonia, fibrosis. Bronchoconstriction. Some of the drugs that can produce bronchoconstriction include aspirin and the other NSAIDs, penicillins, tetracyclines, cephalosporins, chromoglycate, beta blockers, anticholinesterases, opiates, iodine contrast media, N-acetylcysteine. NB. Remember that drugs do not have to be given systemically to produce problems. Even eye drops such as timolol can produce wheeze and chest tightness, particularly in elderly patients. Alveolitis. Some of the drugs that can affect the lung parenchyma are listed in Table 33. Some of these effects are potentially reversible on withdrawal of the treatment, while others may produce irreversible damage. Radiotherapy. Radiation, prescribed with a view to eradicating tumor cells, also damages healthy tissue. When given to the thorax for the treatment of lymphoma, breast, or lung cancer, it can produce a pneumonia in the underlying lung. The risk of damage is proportional to the dose of radiotherapy. Clinical presentation. The clinical presentation will be determined by the nature of the underlying pathophysiology. In general, bronchoconstriction presents with wheezing after drug administration. Pneumonia or alveolitis is likely to have a slower onset, with exertional dyspnea and fine inspiratory crackles being prominent. Investigations. In bronchoconstriction, monitoring peak flow is worthwhile to see if this improves after a couple of days. It is then worth requesting lung function testing before and after a bronchodilator challenge to see if mild asthma or chronic obstructive pulmonary disease has been unmasked. In alveolitis there should be radiological changes visible on plain CXR or high-resolution CT, Fig 25, as well as appropriate changes in pulmonary function tests, reduced lung volumes with a reduced KCO. Radiotherapy produces more localized fibrosis that may progress to cause lung contraction. The edge is often sharply defined, Fig 26. NB. Ensure that patients with radiation fibrosis are told that they have an abnormal CXR, especially if the changes are persistent. This can save them unnecessary investigations in the future. Treatment. For all suspected drug side effects, it is necessary to stop the offending medication and replace with another class of drug if necessary. Patients with bronchoconstriction may also require a bronchodilator, at least in the short term until their symptoms improve, as well as a short course of corticosteroids. In alveolitis, some patients will respond to steroid therapy, in others the damage will be irreversible, but non-progressive. Baseline and serial KCO measurements are recommended by some authorities for patients taking amiodarone and other agents that are particularly associated with alveolitis.